Hello there, and my name is Tiffany Westrich-Robertson. I'm the original founder, CEO of AiArthritis, and a person living with non-radiographic axial spondyloarthritis. Happy to be reporting again from EULAR 2024, where we have a Go With Us to Conferences program that is designed so that people living with AiArthritis diseases can take in the research which is presented for an audience of rheumatologists and researchers primarily in most sessions, and then we narrow it down to the core nuggets of information that you as a person living with an AiArthritis disease would most benefit from learning. So here's my update on a few sessions that had to do with tapering off of medications, off of biologics, and how to withdraw, when to withdraw. And yes, for those of you who have been coming with us to, or going with us to conferences, both EULAR and the American College of Rheumatology that we do in November, so sign up for that too, you may know that this is a topic that has been starting, this prevention idea, which I talked about in a different debrief, tapering, withdrawal because of remission, like my brain, what? This is something that I didn't even think was possible to talk about. And this is something that we are talking about, and it's happening in the research world. And that is just an amazing thing. So in this, I'm going to review a couple of sessions, or not review in detail. I'm going to just tell you some highlights of where this is going. So first, a little bit of a history. So as researchers started thinking about, okay, those patients who are stable on their stable in their disease and on biologic, who would be considered in remission, drug-induced remission, when is it okay to start taking them off so we don't have to be on these drugs for the rest of our lives? And as these researchers started thinking about this and exploring how this had happened, there's been a couple trials where they tried pulling people off like cold turkey, we call it, like just that's it, that you're just done. And then they've also tried the tapering. And what they realized is immediate, just quitting without tapering does not work. Everybody flares. And in some past studies, they had to just put people back on them again. Now, in those studies, interesting fact, not everybody needed to stay on them after the second kind of go around with them. Then as they pulled them off again, it seemed to go into remission in many people. So that is really good for you to know that there is possibility that some people are candidates to go off of biologics. But research is showing it needs to be done in a very careful, tapered way. And even in that, some people still will flare. Not everybody is a candidate. And so the rheumatologist and the patient really have to participate in what's called shared decision-making, or having conversations to decide what's best. Are you a candidate? Are you not a candidate? What are the risks? What are the benefits of doing that? And it really is a case-by-case situation. So some of the highlights, I'm looking on my other screen because they talked about the background and kind of the advantages and disadvantages. So obviously advantages, lower risk of having side effects or drug interactions, that you also, there's cost savings involved. So not only for you, but also for the society as a whole, and the healthcare system. Our drugs are very expensive. And so we don't have to be on them. That's going to save the healthcare system a lot of money, and they can ration it out to other people. So that's a good thing too. The disadvantages, obvious. I think we know as a patient, I didn't even need to look at the slide. Risk of flare, risk for a persistent flare that could not end up being controlled, so we end up in flare for a long time. Risk of structural progression or organ involvement, so just advance of your disease. But then also, they did report that when they asked patients how they felt about it, if they thought that this was a good thing, if there was advantage, no shocker here either, most patients just said they're fearful of flaring and the things I just mentioned. But patients also said that they were worried that if they go off of the biologic that's been working so well and had them achieve remission, and then they're off of it for a while and go back on, it may not work as well. And that does happen. There is a phenomenon where If you're pulled off of one and then you try it again a little while later, it may not be as effective. That is not the norm. That is rare, but it can happen. And so we all know as patients, when you have the right continuity of care, do not disrupt that. So I can understand why that's a fear. So this is an early concept here in 2024. I'll be interested to see when I look back at this in 5 years where we are. But essentially some of the studies, the points that I'm going to point out. So they focused on some tapering and withdrawal of bio, and also they did this with those who are on methotrexate. When is it too early? When is it too late type of thing? And essentially what they found is the predictors of those who, which is no surprise here, the predictors of those who are going to do well versus aren't depend a lot on your biomarkers, meaning are you rheumatoid factor positive? Are you ACPA positive? Do you have high levels of inflammation? Those who have those high blood markers tend to be the ones of most concern to taper or withdraw. Whereas people like myself, who have never had a positive blood lab in my life, true facts there, but I still have disease activity. If I didn't, I would be a candidate because I would be less likely to relapse if I am under controlled disease. And controlled disease is considered 6 months symptom-free. Also keep in mind when you're in remission, any existing structural damage, obviously that can't be undone. So when they mean remission, they mean the disease is no longer active and has just not been active for at least 6 months. There are guidelines that EULAR had put forth that say that definitely taper, don't just withdraw. If, in again, 6 months in remission, that and when they look at the studies with that, most of the patients, once they withdrew from tapering, did do well. Again, a few people had to go back on the biologic for a short period of time, but then taken off. A good percentage of those remained in remission. So there was a small percentage who still had to, who just were candidates. But most of us were, or most patients were. And so that is very hopeful. Also, I'm going to give you an update. There was a drug-free remission. So we're talking about remission, tapering, withdrawal in AxSpa, or axial spondyloarthritis. Some of you, like me, would be diagnosed with non-radiographic AxSpa. There's actually just a pull-out moment for education that we'll use as a little soundbite here. So axial spondyloarthritis is a spectrum. So this is a relatively new way of looking at the disease. Over the last several years, we have what used to be called just ankylosing spondylitis. Now there is an ankylosing spondylitis, which requires radiographic evidence. Those like me without radiographic evidence, non-radiographic, everything's right in the name, all living under the umbrella of axial spondyloarthritis, but they are two separate conditions living under this term. And so there's a lot of people walking around that actually have ankylosing spondylitis still on their record, but they technically should be considered non-radiographic. Good news, treated all the same. That's just the main differentiation there. Okay, so achieving drug remission in AxSpa, it's harder. It's harder for the researchers than in rheumatoid arthritis for a lot of reasons. The lower back pain is a trademark, and it's one of the most reported pain symptoms in the world, low back pain, and figuring out, is it mechanical or is it inflammatory? So just that nature of back pain makes it a little bit difficult. And so in this study, patients were treated with biologic and NSAIDs or anti-inflammatory drugs. So like ibuprofen is an NSAID. And they just did not achieve, they did not achieve good response just on these NSAIDs, and they moved up to a biologic. And so of the 55 patients on the trial, 61.8 achieved remission and 21.8 low disease activity at week 2. So that is after they went on the biologic as well. So it just goes to show you that with AxSpa, early intervention with biologics is super, super important to be able to get to that drug-free remission. That was something that I thought was of interest. And then lastly, when we talk about Steroids. Oh my. Now, this was one in lupus, particularly lupus nephritis when the kidneys are involved. But because that is the condition, that is the number one, that is the go-to. Put them on high steroids. And there's been a lot of talk in the last several years. What is too high? We need to taper patients off of steroids. The immune system, especially since COVID, this has been a hot topic because we realized that people on steroids had much worse outcomes with COVID. So there's been a lot of research and efforts to get patients off of steroids. In this trial in particular, they realized that when they tested patients who had initial steroid of 40 milligrams or more a day, 40 a day, early on in their disease, so somewhere within the 1 in 3 marker. And then for 6 months, they were doing this regimen. And then the comparator had less, but stayed on longer. The people who had the shorter version with the higher dose ended up having more chance of remission than those were on a lower dose for a longer period of time. So they are suggesting that those diagnosed with lupus nephritis, and I feel like this is translatable to anyone, the higher doses early on for a stint of time leads to improved rates of response, of better disease response, and could allow for tapering of steroids more than somebody who is just on it for a long period of steady time. They have less like chance to taper off. So something to talk to your rheumatologist about. So there you go. There are some updates about things happening with tapering, withdrawal, and the remission word, the R word. So that is our update. Let us know what else you want to know in regards to specifics. We try to keep this a little kind of an overview of the points that are most important to you, but we certainly can give you more details and connect you to the research itself. All right. Thank you for joining us for this debrief from EULAR 2024.